So I'm going to open the webinar now. Erica will kick us off just after the hour. Feel free to keep your cameras and microphones off until the hour. People will be joining us shortly.
Hello, everyone, and thank you for joining us. I can see lots of you have joined us online, which is absolutely wonderful. We're so pleased you're here today with us for this presentation provided by the World Federation of Occupational Therapists on peripheral nerve injuries in conflict. We have a great panel today, so we'll get started. Oh, just some housekeeping. So Joe, regarding our languages, so to listen to the Arabic interpretation, which is live audio, please click on the three dots at the bottom right of your screen and then select the globe icon. You can see an example here on the right for interpretation and choose Arabic. You can turn off the English audio if you don't want to hear that as well by again clicking on the globe icon and enabling mute original audio. We will enable interpretation now, and then you can follow those steps to get your Arabic translation. If you would like other languages, we do have caption-based translation, and that includes Persian and also a range of other languages. We don't take any responsibility for that quality, though, because that is an AI function of Zoom. But if you would like to do that now, please go ahead and access your interpretation. So just quickly, some of you will be familiar with this by now, but each webinar will go for approximately 1 hour to allow us to have 30 minutes for discussion. We won't take audio questions from participants, but if you have questions, and we do encourage questions, please put them into the Q&A function at the bottom of your screen. For general comments or greetings or feedback to the organisers, you're welcome to put that into the chat function. But we really do ask that you put your questions into the Q&A function because we might miss them otherwise. This webinar is being recorded, and a recording and transcript will be uploaded to the World Physiotherapy website after the session. And that's also where you'll find the recordings from previous sessions. So I encourage you to catch up if you missed any of them. If you experience any technical difficulties, try refreshing your browser and then rejoining the session. If you're having ongoing problems with Zoom, you can also watch this session on YouTube Live, and the link it will be put into the chat, and the link is provided here as well. And finally, we ask all participants to engage respectfully and professionally, both in the chat and the Q&A. We really have valued so far that we have a really positive and inclusive environment for everyone. These webinars are really focused on sharing knowledge. They're open to everyone, and they must be kept free from political, religious, or military opinions. Thank you very much for respecting that. So, in terms of what's next, it's hard to believe we're coming towards the end of this series. We've had some wonderful sessions. So today is number 8 in the series, and then next Monday on the 25th of May, we'll have a session on communication and swallowing challenges in conflict, presented by the International Association of Communication Sciences and Disorders. And then the following Monday, the 1st of June, we'll have a session on pain management. So now I will hand over to the president of the World Federation of Occupational Therapists, who will provide us with an introduction to the panel.
Thank you very much, Erica. So good morning, good afternoon, and good evening to you all participants, depending on where you are participating from. On behalf of the World Federation of Occupational Therapists, I welcome you to this webinar series on rehabilitation in conflict. And today, the World Federation of Occupational Therapists is hosting this webinar on peripheral nerve injuries. My name is Tekla Mlambo, the World Federation of Occupational Therapy President. I'm a senior lecturer and a chairperson of the Rehabilitation Sciences Department at the University of Zimbabwe in Harare. So my duty is simple. As you may already know, occupational therapy promotes health and well-being by supporting participation in meaningful daily life activities, which we call occupations, and these occupations that people want, need, or are expected to do. So besides the disruptive nature of conflict or disasters in terms of occupational engagement, people in conflict situations are prone to suffer injuries that can affect their health and well-being, and peripheral nerve injuries are a common occurrence in conflict situations. So today we have 3 occupational therapists who will take us through the topic on peripheral nerve injuries in conflict situations, and let me introduce them to you. The first will be Debbie Gray. Debbie Gray is an occupational therapist originally from South Africa, where she trained and began her career, and then she relocated to the United Kingdom, where she has been working in the NHS for more than 20 years, and she has been working primarily in trauma and orthopedics with focus on hand therapy. And alongside her clinical work, Debbie has contributed to rehabilitation projects in Togo, Rwanda, Gaza, Nepal, and Ukraine. There she has been supporting rehabilitation teams and BENS units in conflict and disaster settings. These experiences continue to shape her practice and commitment to collaborative and person-centered care. Then also, in the team, there is Consuelo Alzamora. Consuelo is an occupational therapist with more than 14 years of experience in Haiti, specializing in disability inclusion, rehabilitation, and community-based health initiatives. She is director of Fondation Tours Ensemble, a multidisciplinary rehabilitation center in southern Haiti, and an associate professor at the Faculty of Rehabilitation Sciences of Ligue. Consuelo has supported rehabilitation and emergency response efforts following major disasters in Haiti and currently serves as the World Federation of Occupational Therapists Board Director of Practice, contributing to the global advancement of occupational therapy. And lastly, but not least, we have Dr. Hassani Sasaki, who is an associate professor and founding head of occupational therapy program at Bataji Medical Colleges. He serves as a WHO consultant for assistive technology and also as an International Society of Wheelchair Professionals, wheelchair service trainer, leveraging expertise in humanitarian crisis and conflict response. He has served as a WHO learning on TAP, mentor and Arabic trainer in wheelchair provision for emergencies in Northwest Syria, and has also presented on earthquake-related nerve injury rehabilitation for the Moroccan Alliance of Rehabilitation Professionals. Spanning 2 decades and multiple continents, Dr. Sasaki's career showcases the global impact of occupational therapy. And without wasting much of your time, I'm handing over to the presenters. Thank you.
Thank you, Tekla. Hi, everyone. As we gather here today, my heart is with all those around the globe navigating times of profound hardship, conflict, and disaster. In moments like these, it is vital that we pause to extend our deepest wishes for health, safety, and enduring peace to every individual in every corner of the world. While the challenges before us can feel overwhelming, they also remind us of our shared humanity and the incredible power of resilience. Let us choose to carry a spirit of hope today, not as a passive wish, but as a guiding light that inspires unity, fosters healing, and reminds us that even in the darkest times, renewal and peace are always possible when we stand together. Today, we are focusing on a critical but often silent aspect of trauma care: peripheral nerve injuries within the context of conflicts and disasters. In these high-pressure environments, nerve injuries are incredibly common. However, because they aren't always visible and aren't immediately life-threatening, they are frequently missed or neglected during the initial rush of clinical stabilization. It is rare to see a nerve injury in isolation. They almost always present as part of a complex injury, accompanying fractures, blast wounds, or severe soft tissue loss. Whether the damage is caused by direct trauma, like a shell fragment, or secondary injury from traction and compression, such as compartment syndrome, the result is the same: significant long-term disability for the survivor. As therapists and medics, we must recognize that our repair options in these settings are often limited by resources and time. Therefore, understanding this delicate anatomy, the intricate layers of axons and protective sheaths you will see on the next slide, is our first step in preserving whatever function we can for the patient. My colleagues Consuelo and Debbie will be covering clinical interventional options and talk about this into more details. Next slide, please. The one before. Yeah. Yes, this one. Thank you. So now let's move into a quick anatomical refresher, which forms the core clinical foundation for how we assess and understand these injuries. Peripheral nerves are part of the peripheral nervous system, connecting central nervous system to the body for motor and sensory functions. Key components include neurons, the building blocks with a cell body, the dendrites that receive signals, and the axons that send signals and are bundled together. Myelin sheath, the fatty layer produced by Schwann cells, enhancing signal transmission. And we also have the fascicles, which are bundles of axons grouped together. Also, there are the connective tissue layers, which are the endoneurium that surrounds individual axons, the perineurium that encases each fascicle, and we also have the epineurium, which protects and supports the entire nerve. When we talk about peripheral nerves, it helps to categorize them into three primary types based on their function. First, we have motor nerves. Think of these as the outgoing pathways. They send electrical signals downward from the central nervous system directly to our muscles to trigger movement. When these are injured, we expect to see weakness or paralysis. Second, we have sensory nerves. These operate in the opposite direction. They pick up information from the environment, like touch, temperature, and pain, and relay those sensory signals back up to the central nervous system. And third, we have mixed nerves. In reality, most of our major peripheral nerves, like the median or ulnar nerves, are mixed. They combine both motor and sensory fibers into a single bundle to allow for two-way communication. We as therapists, keeping this simple division in mind is exactly what drives our clinical assessment. By understanding whether an injury has disrupted motor pathways, sensory pathways, or both, we can accurately pinpoint which nerve is affected, evaluate what functional loss the patient is experiencing, and establish a clear, targeted treatment plan. Next slide, please. Moving on to the causes of peripheral nerve injuries, we can broadly categorize these lesions into two main types: open injuries and closed injuries. Understanding the distinction between them is essential because the underlying mechanism directly influences how the tissue behaves and how we approach treatment. First, let's look at open injuries. These are divided into tidy and untidy wounds. Tidy open injuries are typically caused by clean, sharp objects like a knife or glass. The nerve is cleanly cut, and because the surrounding tissue damage is minimal, these have the best potential for early surgical repair if resources allow. Untidy open injuries, on the other hand, are highly complex. These are caused by high energy trauma typical of conflict or disaster settings, such as blast injuries, bullet or shrapnel wounds, severe burns, and open fractures. In these cases, the nerve is often torn or shredded, heavily contaminated, and surrounded by extensive soft tissue loss, meaning surgical repair must almost always be delayed until the tissue stabilizes. Next, we have closed injuries, which generally result from one of two forces: compression or traction. Compression forces cut off blood supply to the nerve, leading to ischemia. This is frequently seen in conditions like compartment syndrome, when a limb is trapped under rubble, such as in a collapsed building, by a bone or foreign body, or even from prolonged sustained posture. Traction forces also cause ischemia, but through severe stretching. This happens during fracture dislocations or when a limb is forcibly pulled during an accident or extraction from debris. An important clinical takeaway to keep in mind here is that nerves are not like muscles. They have very limited elasticity. While a nerve can handle a stretch of up to 6% and safely recoil, stretching it beyond 10% may result in permanent structural damage. Recognizing these mechanisms helps us understand exactly what the nerve has been subjected to, which is the baseline for setting realistic recovery expectations and planning our rehabilitation priorities. Next slide, please. Now that we've looked at the different types of nerves, let's talk about their physical properties, specifically how they handle tension. This is a critical foundation for us as therapists, because how a nerve behaves mechanically tells us exactly how we need to treat it in rehabilitation. First and foremost, we must remember that nerves are not muscles. Nerves cannot be stretched to lengthen in the same way that muscles can. They lack that same structural elasticity. When a nerve is put under stretch, it does have a tiny bit of built-in slack. It can lengthen by up to about 6%, but it will then immediately recoil back to its original length, much like a tight spring. However, there is a very strict physiological limit here. The moment a stretch goes beyond 10%, we cross a dangerous threshold where the stretch results in actual physical damage to the nerve tissue itself. As clinicians, especially in high-stakes conflict or disaster settings where limbs may have been forcibly pulled or trapped, this means we must be incredibly mindful. We have to ensure safe positioning to completely avoid putting unnecessary traction on injured nerves, and we must never aggressively overstretch a limb during our range of motion exercises. Protecting this fragile tissue comes first. Next slide, please. Now let's move on to the core framework we use to understand peripheral nerve injuries, CDON's classification. When a patient presents with a nerve injury, it generally falls into one of three distinct categories, ranging from a temporary signal blockage to a complete structural tear. Understanding these three types is vital because it directly dictates our treatment plan, recovery timeline, and expectations. First, we have category A, neuropraxia. Think of this as a temporary local block. The nerve structure remains entirely intact, but it is temporarily unable to transmit signals, most commonly due to a compression or localized ischemia. The great news here is that recovery is highly favorable, usually occurring spontaneously within days to a few months as the nerve condition and nerve conduction restores itself. Next is category B, axonotmesis. This is a more severe structural injury. Here, the inner axon itself is damaged, but the protective outer insulating matrix and connective tissues of the nerve remain perfectly intact. Because the structural pathway is preserved, the nerve can regenerate. However, it takes time, typically several months, growing at a slow rate of about 1 millimeter per day. We must note, however, that recovery may not always be 100%, particularly with proximal injuries where the distant muscle end plates might degrade before the regenerating axon can finally reach them. And finally, we have category C, neurotmesis. This is the most severe grade. In neurotmesis, the nerve is completely cut or severed, both the axon and all surrounding connective tissues are destroyed. Without surgical intervention, the nerve has no pathway to guide it, meaning functional recovery is highly unlikely on its own. Surgery is almost always required to physically reconnect the nerve ends or replace a graft. As therapists, especially in complex or conflict settings, our immediate role isn't always waiting around for a surgical window. Whether we suspect a neuropraxia that will recover on its own or a neurotmesis waiting for delayed surgery, our priority remains the same. Identify the nerve problem early, protect the tissues, maintain range of motion whenever possible, and preserve function every step of the way. Next slide, please. Moving forward, I want to address a very common misconception. The idea that a nerve injury always requires immediate surgery. In reality, not all nerve injuries are repaired early. As clinicians, we only see early repairs under ideal conditions, specifically when there is a clean, neat laceration paired with immediate access to a sterile environment and microsurgical expertise. However, in conflict zones, disasters, or complex trauma settings, the clinical reality is entirely different. We are often dealing with high-energy injuries from blasts, gunshots, or severe crushes. These wounds are frequently contaminated, unstable, or complicated by extensive soft tissue loss and vascular damage. In these challenging scenarios, surgery must be delayed. Life-saving and limb-saving priorities always come first. Furthermore, we need the soft tissues to settle and stabilize. The true extent of the nerve damage often only becomes clear weeks or even months down the line as swelling goes down and the wound bed matures. This brings us to foundational take-home message for us as therapists. Early nerve reconstruction is rare here, and that's okay. Our job is not to wait around for a surgical window to open. Instead, our immediate priority is to preserve what is there. We must focus on protecting the tissues, preserving range of motion, preventing contractures, and maintaining overall limb function. By starting rehabilitation immediately, we ensure that when the surgical window does finally open weeks or months from now, the patient's joints and muscles are actually in a fit state to benefit from it. Procedures may include nerve grafts, nerve transfers, or FFMT procedure depending on a timing and injury level. The FFMT here stands for Free Functional Muscle Transfer. It is an advanced microsurgical procedure used when a long delayed or severe peripheral nerve injury has led to permanent, irreversible muscle degeneration. Because a target muscle's motor end plates typically degrade permanently if they are not re-innervated within a 12 to 18-month window, in most cases, a standard nerve repair or nerve graft will no longer work due to resource limits or poor tissue condition. Next slide, please. Moving forward, let's talk about what we can realistically expect when it comes to surgical outcomes for peripheral nerve injuries. As clinicians, it is vital that we manage both our own expectations and those of our patients. The reality is that even under optimal surgical conditions, only about 50% of patients achieve useful functional recovery. When we operate in conflict or disaster settings, those success rates can be even lower due to delayed surgical access, wound contamination, and the highly complex nature of blast or crush injuries. However, there are 4 key factors that heavily dictate a patient's capacity to recover, which you see listed here. First, age. Younger patients generally experience much better outcomes due to their superior regenerative capacity and fewer comorbidities. Second, timing. Earlier repair yields the best results. Unfortunately, as we just discussed in conflict settings, reconstruction is almost always delayed while we wait for wounds to stabilize and contamination to clear. Actually, early repair is crucial for peripheral nerve injury healing because it reduces complications and supports natural regeneration as it prevents muscle atrophy. Early intervention avoids prolonged denervation, maintaining muscle function, minimizes scar tissue, reduces obstruction to nerve regeneration caused by scar formation, enhances regeneration. Nerves regrow better when aligned early in the right movement and environment, and early repair leads to better motor and sensory recovery compared to delayed repair. The third factor that affects recovery is nerve type. Single function nerves, meaning pure motor or pure sensory nerves, recover significantly better than complex mixed nerves like the median or ulnar nerves. And finally, distance. Distal injuries have a much shorter distance to regenerate, giving the axons a higher chance of a meaningful return to their target muscles or skin. The takeaway for us here, because surgical outcomes are highly variable and often compromised in emergency settings, our early rehabilitation efforts are paramount. We cannot simply wait until and rely on surgery to fix the problem. Immediately protecting tissues, preserving range of motion whenever possible, and maintaining function is what bridges the gap and gives these patients the best possible chance at independence. Next slide, please. Now let's talk about what happens after a nerve injury occurs, the process of nerve regeneration. To start, nerve regeneration is notoriously slow. On average, axons grow at a rate of about 1 millimeter per day, though it can range between half a millimeter to 2 millimeters. They always regenerate from a proximal to distal direction, tracing the original pathway of the nerve. Because of this timeline, we are working against a ticking clock, particularly regarding what we call motor end plate viability. For meaningful motor recovery to happen, the target muscle's motor end plates must be reinnervated within a strict 12 to 18-month window. If the nerve doesn't reach the muscle within this time frame, those end plates undergo irreversible degeneration, meaning functional muscle return will be permanently limited. This is why the overall recovery timeline can take up to 24 months, with sensory recovery often continuing to progress even longer than motor recovery. As therapists, we also need to look closely at conflict setting considerations. In these environments, regeneration can be significantly slower or even physically blocked due to several challenging local factors, such as but not limited to infection or contamination, which damages the nerve bed and halts every early healing, poor vascular supply, which starves the growing nerve of oxygenation and crucial Schwann cell support. There are also the extensive soft tissue loss and the subsequent dense scar tissue and adhesions, which physically obstruct axonal growth and reduce the nerve's ability to glide smoothly. And finally, blast injuries frequently cause long nerve gaps, massively increasing the distance the axon has to travel, all while associated injuries like complex fractures or burns further complicate our ability to safely mobilize the limb. Understanding this timeline and these environmental hurdles is exactly why our immediate early therapy interventions are so critical to preserving tissue health while the nerve slowly heals. You might wonder why we put the snail here. The image of the snail on this slide is a perfect visual cue to pause and remind us all that patience and consistent long-term rehabilitation are vital for these patients. I hope that was helpful. Thank you all. Now over to you, Debbie.
Thank you, Hassan. Hello, everyone. I will focus now on what we can realistically do in the acute rehab phase when resources are limited, time is short, and service users are often moving between services. So looking at the signs and symptoms now for the acute phase, right after injury, peripheral nerve signs may be present, but they're not always obvious, especially in major blast or complex injuries. Severe pain, swelling, open wounds, fractures, burns, or immobilization can mask early nerve findings. When symptoms do appear, people may describe something like burning or shooting pain, tingling, or loss of sensation. There may be an immediate drop in muscle power, certainly within 72 hours, but this can be hard to see if the limb is, for example, splintered, swollen, heavily bandaged, or simply too painful to move. So in the acute phase, we stay alert. A nerve injury may be there, even if it's not clearly visible. And we can advise the service user to be vigilant of their symptoms too, and seek medical attention, especially if symptoms worsen, change, or fail to improve, if they are moved on and we don't have the privilege of following them up. In the post-acute phase, as swelling reduces and pain settles, the underlying nerve injury often becomes easier to see. We start noticing autonomic changes, be it altered skin color, sweating, skin texture, or changes in hair and nail growth. Muscle wasting becomes more obvious as denervation continues. People begin to move more, revealing compensatory patterns and previously hidden weakness. So the post-acute phase often exposes the nerve problems that may have been masked in the early chaos of complex trauma. Next slide, please. Wait for the next slide. Great. So looking at classic patterns and signs of a missed nerve injury, firstly of the upper limb, and given that in complex settings, the peripheral nerve injuries, as has already been mentioned, are often missed early on because life-saving care takes priority. We can look out for classic patterns, but it's important to remember that I'm just giving some simplified examples here. In reality, injuries may be mixed and may involve multiple nerves, which can blur or complicate the presentation. Understanding the typical motor functions of individual nerves helps you, together with the rest of the interdisciplinary team, start piecing the puzzle together. And don't worry, you're not expected to memorize all of this. There are a lot of resources out there and for you to look up the nerve distributions, and we'll be providing resources that you might find helpful too. Your role is to observe and flag concerns so the medical team can follow up, assess further, and carry out appropriate diagnostic assessment and tests. So if we look at the median nerve, the classic injury sign is the sign of benediction. So when the patient is asked to make a fist, they can't flex the index and middle fingers because the median innervated long flexors, the FDS, which is the middle joints, and the FDP, the flexor digitorum superficialis, the middle, and the flexor digitorum profundus, the tips, if they aren't working properly, if the injury is a high level, the thumb may also sit in an adducted position because opponens pollicis, that's all that brings them around, so pose, is weak or absent. For the ulnar nerve, you may see subtle or marked clawing of the ring and little fingers, the loss of the interossei, and sometimes the ulnar innervated flexor digitorum profundus, depending on the level of the injury, which means then that your knuckle joints, your metacarpal phalangeal joints, hyperextend, and the IPJs, the interphalangeal joints, flex. That's your clawing there. For the radial nerve, the classic sign, which I think everyone knows, is wrist drop. So you've got the loss of wrist extension and finger extension because the radial innervated extensors are not functioning. So these patterns help, may help us recognize the nerve involvement even when the overall injury is complex. So next slide, please. If we look at the lower limb now, we look for similar clear patterns. So when the sciatic nerve is affected, it presents with weak knee flexion and loss of foot movement because both the tibial and peroneal components may be affected. If the peroneal nerve, which is a branch of the sciatic nerve, is affected, the classic sign is foot drop, especially common with fibular fractures near the neck of the fibula. And always check your pin sites, splints, casts, braces, and external fixators. They can hide nerve problems, worsen them, or occasionally even cause them. And I know this has been mentioned in previous webinars, especially the fractures. Next slide, please. So what to watch for with complications? Nerve injuries bring their own complications on top of the trauma. Neuropathic pain is common with symptoms such as hypersensitivity, burning, tingling, and allodynia, which is when a non-painful stimuli can cause pain that is due to the heightened sensitivity of the nervous system. Loss of sensation increases the risk of burns, pressure injuries, and unnoticed trauma, especially in unstable living conditions. Secondary issues include contractures, wound problems, and functional loss. We may also see trick movements. For example, we've seen if the radial nerve is affected and you want someone to supinate the forearm, they can use the shoulder. And there's, as well as a slow regeneration or lack thereof, and occasionally complex regional pain syndrome, which make the rehab more complex. Next slide, please. So if we, in looking at the treatment priorities, we've summed up the guidelines into 4 sections here. So it's safety first, preserve what you can, try identify the nerve problem early, and support the patient. Next slide, please. So our first priority is always safety. When an area is insensate, the person can't feel heat, pressure, friction, or pain. So they're at real risk of burns, pressure injuries, and accidental trauma. We protect the insensate areas from the start, be it through careful positioning, padding, avoiding hot surfaces, sharp edges, and tight straps, for example. And just as important, we educate the patient and caregiver from day one. They need to understand what no sensation means in daily life and how easily injuries can happen without warning. Information often needs repeating to ensure information is taken on board and retained, especially when people are in pain, stressed, or displaced. Next slide, please. So next, we focus on preserving what we can. As safely appropriate, we maintain active and passive range of movement above and below the injury, taking obviously the precautions to account of any of the other injuries. And even if the limb is mobilized. Preventing contractures usually requires a combination of positioning, splints, and gentle mobilization. Managing edema early on is essential. It reduces stiffness, helps with pain, and protects soft tissue health. We also support joint stability when normal co-contraction is lost. For example, in wrist or foot drop, without the usual balance between the agonist and antagonist muscles, joints can drift into end range positions, become overstretched or collapse into deformity. So we can use, for example, splints, taping, positioning, and functional support to keep joints aligned, protect soft tissues, and allow safer movement early. Consuelo will elaborate more on this. Next slide, please. So once the limb is safe, we want to identify the nerve problem early. Which nerves are affected, which are intact, what functions remain, and what secondary issues are emerging in the skin, joints, vascular supply, or soft tissues. When we talk about secondary issues, we mean the problems that develop because of the nerve injury, not the nerve injury itself. As sensation, movement, and co-contraction are lost, we may start to see changes in the skin, stiffness, or early contracture in the joints, swelling or color changes in the vascular system, or muscle wasting and soft tissue changes. These often become visible over days or weeks, especially once the swelling settles and the person begins to move more. But remember, it's not your job alone to identify and definitely not to diagnose the nerve injury. Your role is to observe, screen, and flag concerns so the interdisciplinary team can investigate further. Therapists often see patterns first because we watch movement, function, and compensation closely, and that makes our input crucial. Secondary problems can develop over days or weeks in conflicts, and in conflict settings, service users may not return for follow-up. So clear, concise documentation is essential for safe handover, whether it's across evacuations between services and so on. And you can also just highlight that you're just concerned or just any observations. Next slide, please. So if we're looking at some testing tricks here, firstly looking at sensory quick screens. For sensory assessment, we can use simple tools that are safe in the acute phase. A pen, what may be safe, as long as it's not a big gaping wound. A pen or a light touch sweep helps us compare sides and detect changes in light touch. Light touch gives us a simple sense of whether the skin is responding normally and useful for mapping sensory loss or asymmetry. The sharp blunt testing confirms whether protective sensation is present, which is what matters most for safety. We mentioned the wrinkle test. It's sometimes helpful for children or people who maybe struggle to communicate well or cooperate the other testing methods. It looks at the autonomic supply to the skin, the small sympathetic nerves that control sweating, skin moisture, and blood vessel tone. So if these fibers are working or intact, the skin wrinkles in warm water. If the area is denervated, it stays smooth and rather. But it's really used in acute trauma, and it's not appropriate with open wounds, burns, contamination, or external fixators. We avoid soaking the limb until the skin is intact and immersion is safe. For the motor screens, the quick screens there, I made a mention about the median nerve. Sorry, I am concentrating on the upper limb more here. But we're looking at thumb opposition tests is a good test for the median nerve. Okay, so if the median nerve is weak, the person cannot make a true O because the opposition muscles aren't working. Instead, the ulnar innervated adductor will kick in then and pulls the thumb into, closer to the side and pulling the thumb into more of a D shape. For the ulnar nerve test, it's a Frohman sign. So if the ulnar nerve is weak, the adductor pollicis, the adductor pollicis, if we're looking at tagging on a piece of paper or a card, the adductor pollicis can't hold the paper, so the person then compensates and rather compensates with flexor pollicis longus muscle, so flexing the thumb tip, which is a median innervated muscle. And also looking at finger abduction and adduction also tests the ulnar nerve integrity, or simply just the ulnar digiti minimi finger abduction. So weakness here shows loss of the interossei, which control the fine spreading then with interossei opening, closing the fingers. Do you know that just to do that test, you really want, if it's safe, to get the knuckles straight, because that's when you can see them opening and closing better. Because if you do it yourself, when you flex your knuckles, you don't really achieve much. The interossei can't work effectively. Wrist or foot drop with the radial nerve in the upper limb and the perineal nerve in the lower limb. When these nerves are impaired, the extensors stop working, so the wrist or foot naturally falls into flexion. So functional tasks, we love those as occupational therapists, show us the real world impact of a nerve injury, not just whether a muscle can contract in isolation. When someone pinches a card, makes a fist, or lifts a cup, we see immediately whether the correct muscles activate, whether compensations appear, and whether sensation is good enough to guide movement. These tasks reveal early nerve palsy and subtle deficits that formal testing may have missed. Collapsing fingers from the ulnar weakness, weak pinch from median nerve involvement, difficulty releasing from radial nerve issues or sensory loss, and clumsy or unsafe handling when protective sensation is reduced. By watching how someone pinches, grips, lifts, and releases, we see how multiple muscles, joints, and sensory systems work together or fail to. So this shows us coordination, compensations, the quality of muscle activation, and whether weakness or sensory loss leads to fatigue or dropping objects. Next slide, please. And lastly, from our side, we support the person, not just the limb. In conflict-affected settings, people are dealing with pain, fear, sleep disruption, displacement, and trauma reminders. Their ability to take in and retain information is often reduced. Stress, pain, and fatigue all affect recall. So people may need information repeated several times, and that's normal. It's essential to get the patient and caregiver on board from the very beginning, as others in this webinar series have already emphasized. Simple, safe, repeatable interventions make the biggest difference. And I strongly encourage you to enable the service user and caregiver to carry out the exercises and stretches as early as possible. Give them autonomy. This helps, if possible, this helps them become efficient, effective, and confident, which is crucial during the long rehabilitation period when they may not see a therapist regularly. Clear explanations and reassurance go a long way. Involve the family and caregivers, as I said. They're the key to continuity when follow-up is uncertain. Set realistic expectations. Nerve recovery is slow, sometimes not guaranteed, and outcomes vary. And remember that smoking does delay healing. I'm now going to hand over to my colleague Consuelo. Thank you.
Thank you, Debbie. Well, now we will talk about the caregiver. Caregiver education is extremely important in peripheral nerve rehabilitation, especially when patients have weakness or sensory loss. First, caregivers should help stimulate and move the limb gently while avoiding overstretching or aggressive movements. They also need to monitor careful for burns, pressure sores, or unnoticed injuries, as we know patients with sensory loss may not feel pain or excessive pressure. Another key point is to never pull or drag the affected limb, particularly in brachial plexus injuries. Maintain passive range of motion and safe resting positions is also essential to prevent stiffness and contractures during recovery. In plexus injuries, specifically the shoulder, should always be supported proximally to avoid subluxation and additional strain. Caregivers can also assist with swelling management and help ensure that splints are used safely and checked regularly for pressure areas. And because insensate areas cannot properly detect temperature, patients should avoid hot water or extreme temperatures to reduce the risk of burns. And finally, the limb should be protected from scratches, thorns, pets, or small injuries, and any wound should be cleaned promptly to avoid infection. Well, overall, caregivers play a major role in protecting the limb, supporting recovery, and preventing secondary complications through rehabilitation. Next slide, please. Now, we always need to have in mind red flags. So we want to highlight some of them. These are situations where we should stop treatment and escalate or refer immediately because not every sensory or motor deficit is only a nerve problem. The first one is compartment syndrome. If the limb is red, hot, swollen, and the patient has severe pain, especially pain that increases with passive movement, this is a medical emergency. The increased pressure can compromise muscle, blood vessels, and nerve very quickly. Another important red flag is possible DVT, deep vein thrombosis, or PE, pulmonary embolism. If the patient presents with a swollen, pain limb, pulses are absent, shortage of breath, we must stop treatment and refer. We also need to be careful with an unstable fracture. Check our patient to see if he has severe pain, abnormal movement, or visible malalignment may indicate that the fracture is not stable enough for rehabilitation yet. And finally, unstable cervical spine or possible cervical involvement. If symptoms are bilateral, associated with neck pain, headaches, reduce of cervical range of motion, or generalized weakness and fatigue, we should think beyond a peripheral nerve lesion and consider serious complication and consider cervical or central involvement. The key message here is that as a rehabilitation professional, we have to constantly screen for signs that require medical attention. We need to be able to recognize these red flags early so we can prevent serious complications and improve patient safety. Next slide, please. Now, we want to briefly review some of the key treatment components. One important principle is early and frequent mobilization. We usually encourage both active and passive movement around 4 to 5 times daily. This helps to maintain joint mobility, prevent stiffness, and support functional recovery. At the same time, we also need to protect the limb with splints, slings, or other supports that may be necessary to maintain proper alignment, protect healing tissues, and prevent secondary deformities. Comfort is another essential aspect. Helping the patient establish comfortable resting and sleeping position can significantly reduce pain, swelling, and stress on the injured nerve. Now, when fractures are involved, early weight bearing should begin as soon as the fracture is considered stable and medically safe. Education is also a major part of treatment. Patients and caregivers should be taught how to repeat exercises safely and independently at home. Electrode therapy may sometimes be used, but only when appropriate and only if the clinician has the proper training, please, knowledge, and skills. And the same applies to neural gliding techniques. Neural gliding can be very beneficial when there are not contraindications, but it should never provoke paresthesia or increase symptoms. And it should be only performed by professionals with appropriate training and skills. And something that we cannot forget is that we should continuously constantly monitor for recovery. We should track emerging muscle flickers, sensory change, and progression of tactile signs, as this might indicate nerve regeneration. At the same time, rehabilitation should always promote meaningful function. This includes task-specific practice, adaptive strategies, and early motor re-education once renovation begins to help the patient relearn movement and return to daily activities. Overall, treatment should always balance protection, movement, function, and patient education through the rehabilitation process. Next slide, please. We want also briefly discuss the sensory re-education and especially why it is so important to begin early. So even before sensation fully returns, the brain is already changing after a nerve injury. Without sensory input, the cortical representation of the affected area can begin to decrease, what we sometimes describe as cortical forgetting. So early sensory re-education helps prevent this process by also reducing the risk of pain, neglect, and maladaptive movement patterns. It also supports functional use of the limb, even before sensation returns. There are several simple but important early strategies we can use. First, we need to protect the affected area, right? Patients should be taught safe handling techniques, regular visual skin checking, and how to avoid heat, sharp surfaces, or injuries that may not feel because of sensory loss. Another important goal is maintain cortical representation. One way to do this is through bilateral activities where patient touches or use both sides together to help maintain awareness of the affected limb. We also involve multiple sensory systems, including vision, sound, vibration, and temperature. Guided sensory input should be graded and progressive. We may begin with light touch, tapping, or vibration, depending on tolerance and the stage of recovery. Sensory retraining can also be functional and accessible. We can use simple texture the patient already has available, such as a cloth, a sponge, rice, or sand. Texture retraining should also be graded, moving progressively from soft textures to rougher or more irregular surfaces as tolerate. Dexterity and object differentiation activities are also very useful. Simple pickup tasks can help encourage recognition of shape, size, and weight using both vision and touch together. One example that we can use is the mover pickup test adapter for early rehabilitation. We use 10 small familiar objects and the patient performs a timed pickup task into a container. Depending on the stage of the recovery, the activity can focus on object identification using vision, sensory retraining with or without vision, or dexterity practice when sensation remains limited. Here, the important message is that sensory recovery is not passive. We need to actively stimulate and retrain the sensory system. Next slide, please. So, splints. Now we want to discuss splinting, which is a very important component of peripheral nerve rehabilitation. The purpose of a splint is not only immobilization. Splints help protect tissues and support healing, especially after surgery or during the early recovery phase. They are also important to prevent contractures and deformities. And another key role is compensating for motor loss. For example, in a radial nerve palsy, a splint can help maintain wrist and finger extensions to improve hand function during daily activities. Ultimately, the goal is to enhance function and participation, and specifically if it's important to use a minimalistic and sustainable approach. Sometimes simple, accessible splints can make a significant functional difference. When we think about splinting across phases in the acute phase, we often use immobilization and accessible materials. This may include POP slabs, slings, aluminum finger splints, thumb taping, knife foot splints, or prefabricated orthoses when available. Later in rehabilitation, when possible, patients may benefit from custom orthoses for more specific function support. But regardless of the type of splint, orthosis should ideally be lightweight, comfortable, easy to put on and remove, and follow up the principles of less is more. Safe splinting is very important. I will go fast with this. We need to monitor pressure areas, fit, comfort, skin condition, and wear time regularly. We can't forget about the way we secure the splint and place the strap, the anatomical landmarks, and a splint may also need adjustment over the time because swelling and dressing can change during recovery. Next slide, please. Before giving a splint to a patient, there are several important safeguards we always need to consider. First, education. The patient and caregiver need to understand why the splint is being used, how to wear it, how long to wear it, and the importance of safety checks, especially regular pressure on the skin checks. We should never assume that the patient or caregivers know how to use the splint correctly. It is very important to check that they can safely put it on and remove it independently and correctly before they leave. Sensation is another major consideration. If the patient has sensory loss, monitoring becomes even more important. We also need to consider cognition. Can the patient understand the instructions, follow precautions, and use the splint safely at home? If not, caregivers' involvement becomes essential. Pain should always be monitored closely. A splint should support and protect, not create or increase pain, pressure, or discomfort. And finally, we need to assess wound and skin conditions. Healing tissue, fragile skin, edema, or surgical wounds may require modification in splint, designs, wearing schedule, or monitoring. So overall, issuing a splint is not only about fabrication, it also involves education, safety, follow-up, making sure that the splint is realistic and manageable for the patient's daily life. Thank you. Over to you, Hassan.
Thank you, Consuelo. Hi again. So now let's shift our focus to an aspect of care that is just as critical as therapy, but often overlooked: the mental health and psychosocial support, usually referred to as MHPSS. The integration of mental health and psychosocial support into the rehabilitation and medical care of someone who has experienced a damage to their peripheral nerves is crucial. When a patient experiences a peripheral nerve injury, they aren't just dealing with a physical wound. They are processing a profound sense of loss, paralysis, sudden sensory loss, and relentless chronic pain can deeply fracture a person's sense of identity. It robs them of their independence, affects their ability to return to work, and severely limits their social participation, frequently triggering deep anxiety, frustration, and a low sense of self-worth. Compounding this is the nature of nerve pain itself. The neuropathic pain, constant paresthesia, and extreme hypersensitivity are highly distressing to live with day in and day out. It quickly leads to irritability, emotional exhaustion, and severe sleep disruption, leaving patients with very little cognitive or emotional reserve. Furthermore, in conflict or disaster settings, these injuries rarely happen in a vacuum. Our patients are often carrying acute post-traumatic distress and intense fear from the violent event or blast that caused the injury. We as therapists must be highly sensitive to the fact that simple trauma reminders during rehab sessions can easily re-trigger this distress. Ultimately, the vocational and social consequences are heavy. It is incredibly difficult for these patients to return to work or resume meaningful roles with their families, which places them at a high risk for social withdrawal and reduced community participation. As rehab professionals, we must remember that we are treating a whole person, not just a damaged nerve. Recognizing these psychological and psychosocial barriers allows us to approach our physical interventions with the empathy, patience, and holistic support these patients truly need to heal. Next slide, please. As we wrap up today's presentation, I want to leave you with a few core principles that should guide your practice every time you treat a peripheral nerve injury. First and foremost, remember our core purpose. We are here to restore maximum independence. To do that effectively, we have to provide patients with realistic expectations and build their self-management skills right from day one. Start early with basic range of motion, progress to splints and resensitization, and always ensure your patients can continue their rehab independently long after they are discharged. If there is one take-home message I want you to remember, it's this. In conflict or disaster settings, early nerve reconstruction is rare, and often it's simply not appropriate. Instead of waiting for a surgery that may be far down the line, our focus must be on protecting tissues, preserving range of motion, preventing contractures, and maintaining function while waiting for that surgical window to open. Do not forget that clear documentation and consistent monitoring are what will ultimately guide the medical team on when a referral for reconstruction becomes feasible. So what are our key priorities here? In every single session and with every intervention, I want you to think: soften scar tissue, prevent contracture, control pain and desensitize, and above all, think function, meaning maintaining and or improving functional performance in terms of independence, safety, and quality. Finally, our clinical foundations keep us grounded. A strong knowledge of anatomy improves your assessment, and a good assessment is what drives an effective, prioritized treatment plan. But as clinicians, let's look beyond just the physical injury. Always be deeply mindful of the profound psychological impact of that trauma, injury, and displacement have on the human being sitting in front of you. Next slide, please. Finally, and on a positive note, I just want to say to our listeners today that every one of you is special and unique. You are trailblazers, pathfinders, game changers, powerful, and together you are unstoppable. And because teamwork makes the dream work, I invite all of our amazing participants and colleagues today to team up to translate our webinar insights and take home messages into a strong shared commitment moving forward. I keep saying, you health and rehabilitation professionals are true leaders of change and progress. So let's all work together, get involved, and help others understand our vital role and what we do. Thank you so much for your time and for the vital work you do every single day. Back to you, Tekla and Erica.
Thank you so much, Hassan, and thank you to our panelists. I think there's been great presentations. So we have time for a couple of questions. The first one, I'm going to come to Debbie. We have a question saying, I think, and it's a brilliant question. What if the patient will never get better and all the rehab we do will improve nothing for the patient? What should we do?
Thank you to the participant that asked that. It's really struck my heart because in reality, this happens. The patient, the nerve injury may be complete, and at that time, when you see them and take them through rehab, you might not see change. There may never be change, but all that you do is, and I can promise you, is definitely not wasted. We aim for pain-free function. That function might not be the function they had before the injury, but we are looking at broad function, whether we, and that's preventing the contractures, we're managing the pain, and all of these things together will improve them overall for their function. So it's hard because we might hope and want that to happen. We also might not have access to what they need surgically or the medical intervention at the time. But all we talked about, the basic principles, stick with scar desensitization, freeing up from the pain, and looking at the different options and preventing contractures is what I would honestly say. And it does make a difference. I hope that helps a little bit.
Thanks, Debbie. And then we'll come to Consuelo. And Consuelo, I'm actually going to give you 2 questions if you could answer them both. So the first one is, are there any tests or diagnostic tools like X-rays that we can use to diagnose the type of injury and whether or not there's a nerve injury? And the second question is about pain. Will the pain be along nerve distribution or particularly where the nerve injury occurred?
Thank you, Erica. Yeah, so, well, for the first question, X-ray do not show the nerve, right? There is another main test like nerve conduction studies, electromyography, but they are not always available. So what we do use more is a clinical examination, functional assessment, and as we saw during the presentation, right? We look for signs as weakness, sensory changes, pain, altered movements, patterns, or functional difficulties. But in settings that we don't have a nerve conduction studies, electromyography, ultrasound, MRI, etc., we stick with the clinical assessment and functional assessment. Yes. And sorry, the second question, it was about pain.
Yes, is pain most likely to be seen along the distribution of the nerve or at the site of the injury?
So it will depend of the injury, right? What kind of injury is and how affected is the nerve. So usually it goes through the nerve, through the limb, or from after where the injury is, going through like distal from the injury. So you can follow through the nerve. And if it's an upper or lower extremity, right? Yes. Thank you.
Thank you. And then we'll come to Hassan. Hassan, can you tell us about some of the techniques or approaches that therapists can use to improve adherence to therapy, and particularly in locations where maybe access to therapy might not be really easy? How can we make sure that these patients who have these really long-standing injuries that are slow to heal, how can we maintain their engagement with treatment and adherence with therapy? Thank you.
Yeah, thank you. This is actually a good question. It's challenging but feasible. So patient adherence during PNI recovery is uniquely challenging actually, because nerves regenerate incredibly slowly, typically around, like I said earlier, 1 millimeter per day. So patients often face months of intensive therapy with little to no visible progress. So it comes with, frustration, depression, rehab burnout, and so on. So to maintain long-term adherence, rehab strategy must blend clear education, and education is key here. So we must educate the patient, the family members, caregivers, or even the legal guardians, in addition to providing a practical goal setting. And these goals should be written, approved by, and consented by patients themselves. And in addition to provide some psychosocial and behavioral support. This is really crucial and imperative in such cases, especially in times of crisis and conflicted or affected areas. So this will, of course, definitely will come up with more positive, significant impact of the clinical interventions that we provide to the patient. It will also help better adherence to the client to follow not only at the clinic, but also when they go back to their home. And part of it is educating the family on how to deal with such conditions when they go back to home, because, the families, they live with the patient 24/7. They might be able to come maybe one time a week or maybe less to the clinic because of the situation and the challenges out there. So it's really crucial to get family members involved as well into the process, and I believe this is a key successing factor in the whole process from the very beginning, from day one. Yeah.
Thank you. And Consuelo, I'll come to you. We have a question about peripheral nerve injuries in children. So, are there any what would be your considerations? Are there any additional red flags or ways of assessing for red flags? And what are some of your considerations around managing peripheral nerve injuries in children? Thank you.
Yeah, well, I think one of the most important is that sometimes too, the kid will refusal to use the limb, and you will see like why they don't want to use it, or they can be like a little bit irritable, right? Maybe we will not see like swelling or color changes, but we can see like why they don't want to use the limb. If it's not broken, we don't like there's not fracture, right? They positioning a little bit weird too. And maybe it's very important that we, as we said, like we can see the skin, we can check, because maybe there is some little injuries that we have not seen. But I think like one of the most things that I have seen in kids is that they don't want to use the limb, and there is not fracture, there is nothing. And sometimes we can't recognize well the swelling or other like red flags, but the way that they are not including the limb to use that in their activities, that's something that we have to check. Yes, and the irritability. Yeah.
Thank you so much. We're going to do 2 more questions. I know we've got lots of questions in the chat, and we will try to answer them in a document that will be put on the World Physiotherapy website. But I'm just going to do 2 more questions. Firstly, Debbie, I think this is a really great question about skincare, and I'm going to elaborate on it a little bit from my experience. But we're talking about conflict, and so we know that a lot of people affected by conflict are displaced. They're living in temporary accommodation. They don't have access to clean water or sufficient water. I've personally had experience of people with affected upper limbs having a lot of skin problems in their axilla. Can you give us some suggestions about the risks and the ways people who don't have access to all of the things that they might like to have access to, how they can keep their skin, intact and healthy? Thanks.
Thank you. Great question. I'm presuming that wounds are healed and it's because of a lack of sensation now that we are taking precautions. Am I understanding that correctly then? Yeah. Okay. So great question. So when it comes to something like the hand, like median nerve is a classic one, is that if you're lacking the sensation on the parts where you would immediately go to grip something. So for example, if you're picking up a piping hot cup of chai and you're with the hand that is not giving you good sensory feedback, the strategies would be to test with another part, to always introduce some other part or the other hand, the non-dominant if it is the dominant affected, just to check the temperature. And the similarly with working with water or with dealing with different textures, or for example, even meal prep when you are using sharp knives. So it's looking at either also adapting, having different methods of doing things instead of, for example, chopping or doing really practical tasks like that, but checking for having strategies in place to think about that. When it comes to the feet as well, it's whatever footwear you can, I would wear footwear, and that might not look like your standard trainer, but I know where I'm from Africa, sometimes, I don't know, for patients even with leprosy, would look at using adaptate. We used to use tires and making soles for shoes nuts. So it's protecting and always checking the skin, having a regular check-in with the skin, knowing, and if you can't see parts, if there is some merit to use. Is that helpful in any way? Hopefully.
Thank you. All right, last question. Consuelo, I'll come to you first, and then I might ask Hassan to add at the end. I think this is, again, also a really great question, and it's from our colleagues in Gaza, and we're very grateful that they've been able to join us today. So in the context of complex peripheral nerve injuries, due to the conflict, the high rate of nerve injuries and other factors, and considering in particular surgical delays and limited resources, what are the most important early clinical indicators that differentiate between transient neuropathy and progressive loss of neurological function? And how does this change the plan for early functional intervention? So I think that this may also relate to the fact that in Gaza they have had a cluster of Guillain-Barré syndrome cases and some other kind of progressive neurological disorders that don't always they're not able to do a lot of the diagnostics for. So if you could have a chat about that, please, Consuelo.
Thank you. Yes, well, my clinical experience has been always in Haiti. And in Haiti, we don't have any kind of exams, or we don't have doctors to have surgery. So we work on that context, like always. But I think some important early clinical indicators can be worsening weakness over time rather than stabilization. Like it will continue expanding sensory loss. I think if we have a pain, a neuropathic pain that continues increasing, muscle wasting, right? If we see that we continue like losing, right, muscle activity, we see that the autonomic changes they get worse, right? The color, temperature, and we see that there is no progression of recovery signs. So I think that's one of the signs that we have in mind when we say, this will be transition, or it can be better or worse, right? But I think as we were talking with Debbie about this, like we will not know at the beginning, right? But we always have to have in mind, like, protection, positioning, maintain range of motion, sensory stimulation, progressive activation, and, as we say, like, functional and always monitoring. So the principles, the first day we will not know, like it will see the same, it will look the same, but as weeks, then if we see the things that I already said, like, okay, we can say, this is not transitional, but the principles of protection, positioning, maintaining, and sensory stimulation remains the same. So I don't know if that answer a little bit the word. Hassan, if some of my colleagues wants to add something.
Thank you, Consuelo. Well, this is really important question, and God bless all people in Gaza and the whole world. So I just want to say that early detection and early screening is crucial and imperative here. And in Gaza's conflict setting, distinguishing transient neuropathy from progressive loss requires rapid, low-tech clinical triage. And, we just want to deal with what we have in hand. So my recommendations is to start with the basic sensory motor testing that are almost available, and cost effective, basically for every therapist and rehab professional. So what you should usually do, you should start with the basic testing that don't require much time and don't require that much equipment or supplies, such as, but not limited to, the light touch, the double simultaneous stimulation tests, the two-point discrimination, localization testing, such as the proprioception kinesthesia or the graphesthesia test. These are all simple tests. In addition to sensation of vibration through the tuning fork, it's a very simple test and you can do it within a few seconds. Also, there are other important indicators that we need to investigate further into and integrate into our screening, such as the sense of weight, pain, temperature, like Consuelo said, stereognosis, ability to sweat through a very basic and simple test, which we call the non-hydrant test. And of course, all of those, can lead to some indicators. So in terms of transient neuropathy, you can find preserved, even trace deep sensation, intact autonomic function, and stable or improving pain motor function over short sequential evaluations. In terms of progressive loss indicators, you might find rapid spreading anesthesia, ascending motor paralysis, loss of trophic skin changes, and expanding hematomas or hardening compartments compressing the nerve. So what is the impact on treatment plan here? So transient cases bypass scarce surgical tracks and should be managed immediately with low-cost protective splinting and active movement. Progressive loss signals and urgent emergency, on the other hand, mandating immediate triage for surgical decomposition, of course, whenever possible, or shunting to prevent irreversible axonal death, maximizing the impact of limited operative resources in Gaza. I hope that answers your question.
Thank you, Hassan. Consuelo, please.
I just wanted to add a little thing. Anamnesis is so important, like to know how it started, when it started, why it started, like, so we can differentiate too also, like if it's coming from shock or if it's coming just suddenly, right? That's something that we have to have in mind all the time.
Yeah.
And don't forget that you got the whole medical team. If you're not concerned this is out of your remit or your comfort zone, we're not there to diagnose. It's the whole team approach, as everyone said before. Yeah.
Thank you. We've run out of time and we have so many more questions in the chat, but Thank you everyone for your engagement. Thank you to our brilliant panelists. Yeah, I think it's been a really great session today and a topic that's really needed and there's multiple comments in the chat about how people in conflict areas are seeing these injuries a lot. I'm going to hand over to President Tekla from the World Federation of Occupational Therapists to wrap us up, and we will see you all next week for the session on communication and swallowing. Thank you, everyone.
Thank you. Thank you very much, Erica. Oh, what a brilliant webinar that we've just had. Let me take this opportunity to thank our presenters, Debbie, Hassan, and Consuelo, for such an enlightening and excellently presented webinar on peripheral nerve injuries. The presentation, I'm sure you all agree with me, that is not just relevant in conflict or disaster settings, but even in other settings. And also let me take this time also to thank our World Physiotherapy colleagues, Erica and Chloe, and the team behind the scenes. I know there are lots of people behind the scenes making it, to be successful, and also the WF40 operational management team for coordinating this very important webinar. Thank you to all our participants for attending, and we could see we're actively, engaging in what was going on. Thank you very much for that. And as rehabilitation professionals, we are stronger together. Let this not be the last, but the beginning of long-term collaborations among the rehabilitation professionals, even at regional and local levels. Thank you, everyone. Enjoy the rest of your evening or morning or afternoon. Thank you and goodbye.